So Sam is 12 years old boy on anti-epileptic medication. So metaclopromide was given for him to control the vomiting, and he developed worse side effects. Okay. Answer the concerns of the mother.
What's the name of the patient again? Sorry, I forgot.
Sam.
And
Answer
and
the
mother name?
concerns of the mother, Mary.
Mary. Okay.
Okay, 2 minutes for you. Once you are ready, tell me. Okay, you can start now.
Okay. Good evening.
Good evening.
My name is Dr. Yasser. I'm the treating physician of Sam. I think you are Mrs. Mary, mother of Sam.
Yes, doctor, this is me.
Okay. Thank you, Miss Mary, for come to discuss about Sam condition.
Okay,
Would
thank
you-
you, doctor.
Yeah, I have reviewed your GP letter, and he mentioned some your concern. Would you like to tell me what is your most important concern?
Yes, doctor, my son Sam was given this medication because he was having vomiting. He was being prescribed this medication, and he suddenly started to have, he developed fits. This made me too much worried, and I am very much anxious. Why did this happen to him? The medication name is Moxolon.
Okay, Miss Mary, I can understand your situation, and I know that your GP prescribed this medication for to control the vomiting. But do you know, have he ever before used this Maxolon?
Don't ask, you are asking the question. No, don't ask the question.
Okay, okay, Mrs. Mary, I sorry to know about that one. Yeah, it was fit, and I told you and telling you that this drug is ideally not to be used in some patients who have just like any seizure disorder, because this drug causes fits in that one. Are you with me?
Okay. Yes, doctor. Oh, my son uses some medication for the seizures. So this may be the reason he has this.
It could be one of the possibility, but other possibility that I told you, most of the time we are not using this drug in those patients who have fits. So this drug can also cause this seizure. Are you understand?
Yes, doctor, but can you tell me, I did not see like exact seizure in him. There were some different abnormal movements. So why this happens with this doctor? Does he has any problem in his brain now?
No, actually, this drug also it is very good drug for controlling the vomiting. But I told you that this drug also has some side effect as like other medication. So it is one of the side effects of that that you are mentioning. This shaking movements of the body, our body becomes stiff. So it is one of the side effects of this medication. Are you with me?
Yes, doctor. So actually he has migraine and he has to take some medication for vomiting. So what can we do now? Is there any alternative for this?
Yeah, we have other very good medication. that we can use to control this if
And
he has again this nausea again with migraine.
okay, he was well controlled with from over a period of time with his medications. So this medicine caused him to get the fit again. So does he needs now extra medication for his control of the fits?
No, we can continue the same medication to control the fit. But I am here to tell you about that if he has again this this feeling of throwing, he can difficulty in throwing the other thing, then we can use other medication than this. Because as I already mentioned you, those children who have this seizure like activity or seizure are on the medication that control the seizure. This drug can predispose to the you can say jerky movement of the body. So you can continue your medication, but we can use other medication to control the throwing out episode in the future one. Are you with me?
Yes, doctor. So how can we prevent this? Anything we can do to prevent this?
Yeah. But just like as I told you, as you mentioned, he has a migraine. So whenever he has a feeling mild headache or something, he can goes to the in calm area. He can switch off the lights. He can sit in a room, and there are other
Six
medication
minutes,
that we
3
call
minutes left.
okay, that are we can call diphenhydramine, these and other medication that we can use to control the vomiting associated with migraine.
Okay. So doctor, I also see that there is excessive sleepiness with this drug. So what to do for this? Can they attend their classes? Can they go to the practical classes? Means if they have to use some instruments there, is that fine if they are on this medication?
No. He can use, but it's very difficult because he can become drowsy, he can fall down there, and there are chances to that he can get faint. So it's better we have to avoid to go there. And how can we cope this one? We can first of all, we don't have to use this medication, or if we feel more drowsy, we have to call 999, or we have go to the accident and emergency department. And otherwise, if he's fine, so he can sleep at home, and he has to inform his doctor, and he has to discontinue this medication. Hope within few days this sleepiness and will finish. Are
Okay.
you with me?
Yes, yes, doctor. What else side effects can we see with this medication?
They can do, as we told you, there is a severe allergy in the form of difficulty of breathing, any whistling sounds, any redness of the face, any swelling of the face and the lips and the mouth and the tongue, causing difficulty in problem. And if he has any loose poo, and if he has any shaking movements, any stiffness of the body. So I think so these are the major problem that whenever anybody has suffered, he has to call 999 or inform his doctor.
Okay, doctor.
Okay, Mrs. Sam, I think we discuss a lot of things. So just summarize that, as you know, Sam is taking anti-seizure medication, and he developed vomiting, and we use this medication, he become stiff. So that's it's look like seizure, but it is not a type of seizure. And the only we discuss about the side effects of the medication and how can we treat them, and what the indication that we can contact 999. Do you have any other concern?
No, doctor.
Thank you. Thank you, Mrs.
Did you give the
Mary.
leaflets?
Yeah, I read the leaflet.
No, no. Did you offer the leaflets here in the communication?
Oh, sorry, I forgot.
No, and also in
Website.
the starting there was some problem. I did not see you asking for the attender and also for the previous knowledge. You started telling that I received a letter from the GP like this. But in communication, you have to ask for the previous knowledge from the mother. I think you can tell like this in the history, but in the communication, ask the mother, what does she know about the child before starting about the communication. So this previous knowledge was not asked, attender was also not asked. Okay.
Yeah, sorry.
One more thing, nowadays they are saying that 1 or 2 questions you can ask, no problem in the communication.
But I
If
don't
you are
know.
not so, yeah, if you are not so clear, you can ask 1 or 2 questions. And one more thing, this is actually scenario, maybe I don't know, this scenario came in the examination. So we'll have to convince and convey your message that that was not a epilepsy seizure actually activity. That was the side effect of this drug that can cause the uncontrolled muscle movements or shaking of the body or tremors. Actually, these are the side effects which are attributed to metaclopromide. Okay,
Can you tell
these are
again
the side effects.
the tremors? What else?
Side effects of these metaclopromide, tremors or shaking of the arms or legs. This is the side effect. And uncontrolled muscle movements like smacking, chewing, lip smacking, chewing, or tongue movements can be there, or any unusual muscle movement. These are the side effects. And it can occur within 2 days of the treatment.
Okay, but here in the leaflet it is given, it can be like an abnormal movement, or they can also cause fits to a person who has.
Yeah.
They
Yeah,
can
this
also,
is actually that's why I am saying that we don't know the scenario. It was scenario for the side effects of the metaclopromide, or it enhanced the seizures.
yeah, we have
So
to know
because
in
this,
both the ways. So
yeah,
we know it can cause in the same child who is taking, it can cause like
yeah,
the extrapyramidal side effects, as you said, like tremors, shaking of hands, and
yes,
some uncontrolled muscle movements, like what happens in
yes,
Parkinsonism.
yeah.
Like features of
Actually,
Parkinsonism,
one,
right?
yes, one more thing is that uh, I don't know what was the scenario actually in the exam. So here we will have to convey the message that we will have to see that this was actually epilepsy, or we have to see this is the side effects of the drug.
Yeah.
One
How
more
to
thing, this is
present it in this scenario.
yeah, indication for the metaclopromide in children, especially if they have epilepsy already or seizures activity, they should not take the metaclopromide. So maybe that scenario was about the apologize scenario. So we apologize that we have given this medicine. This is contraindicated actually in tardive dyskinesia, in epilepsy. These are the contraindication. There we should
Yeah.
not use.
So maybe the scenario would have come in a different way. Maybe
Yeah, yeah.
maybe
That's why we don't know
pyramidal
if
side
the,
effect, or
yeah, maybe
maybe
they want to ask you about the extra pyramidal side effects. That was the scenario one. Maybe the scenario was apologize scenario that we have given this medicine that should not be given in epileptic patient,
because
or
it
if
can
they have any,
enhance the epilepsy.
yeah, yeah, or they have maybe stomach or intestinal problems, we should not be given in, like if they have bleeding, perforation or blockage, so we are not giving the metaclopromide. So these are tardive dyskinesia, these are the side contraindications. So this may be the second scenario. The third scenario may be the mother hidden agenda that this metaclopromide has been given and that caused the epilepsy. So the next time should be given the red flags. So red flags here will be in metaclopromide will be red flags if the any time if it has been given and child is allergic to metaclopromide, or if he develop this extrapyramidal effects like the muscle movements or shaking of the legs or arms, or the child become drowsy or loss of consciousness. So that should be immediately contact to your doctor. So these are the red flags.
Yeah, maybe
Okay.
because maybe they did not check that the child had anti-epileptic. The child is on anti-epileptic medication and known case of epilepsy. Without knowing,
Yeah.
they would have prescribed. So the
Yeah.
mother can be angry also here.
Yeah. This can be income three kind of scenarios, which I have told you. Maybe you will have to tell that next time if you are going to take medicine for your child in GP, you should tell that Sam is having epilepsy, so that he knows this should not be prescribed. Or if he has having any liver disease or kidney disease or any muscle movements problems already, so that in that way it should not be given. Any heart problems, in the heart problems we are also not giving metaclopromide. So these are the actually the red flags that we not red flags that gives you advice to the mother, and the red flags which I have told you already. So just to boost our knowledge, so all these scenarios can come. But I remember one thing, this may be come in 2019, which I remember that somebody has written in the group that they want to ask about the extrapyramidal effects of the metaclopromide. So this scenario was about the side effects of the
The
metaclopromide, which I remember.
extrapyramidal effects are the tremors,
Yeah, which I remember.
shaking.
I don't know. I'm not sure quite enough that my memory is telling me this scenario came in 2019, I think.
Yeah.
It,
This is one of the scenarios which is in the recents, like 2019 and 20 and 18.
yeah. So yeah. This scenario was about they want somebody has written in the group that they want to ask you about the extrapyramidal effects. So that was not actually a epilepsy. That was the extrapyramidal effects. But still, we will have to tell that the next time if you are going to your GP and GP want to prescribe the medicine for the vomiting, so he should be aware of that Sam is having this epilepsy, and he should not prescribe, because this is the one of the contraindication to prescribe metaclopromide. So this is actually.
Okay. And also this, what I was asking about the alternative. So how you will answer for the alternative?
Actually, alternative we cannot say. I don't know. In our general practice, we are using this.
Dancetron.
Yeah, this one we are using. So
But
I don't know.
dancetron is used as off-label in children, right?
Yeah, that is off-label. So we cannot say that what may be the, I don't know actually. Maybe there are some medicines, but we cannot even, I don't know what they are giving.
Okay.
Just like we can say maybe this dimenhydramine.
But diphenhydramine is antihistaminic.
Antihistamine is using. Yeah, it's using in what we call this morning sickness in females. It's also using in small children. Because before this one metoclopramide, people are using the same. Now they are using this dansatron, granisatron, these group. Before they are using the same this uh, Gravinate. Gravinate is very popular brand. Maybe Dr. Ruhel knows.
Yeah.
In Pakistan, it's very popular. In diarrhea, loose, this Gravinate, everybody is using. This is antihistamine.
Okay.
And even this this Gravinate also using when they develop extramedullary side effect. IV, AVL injection they were using. The advanced drug is procyclidine for this one, this extrapyramidal effects induced by this.
For that, I think we should give the answer like diplomatically. We can say that if anytime he developed the vomiting, you should contact to your GP, and you should tell that he's having epilepsy, so that he will be careful next time to prescribe this medicine, and he will see what is the diagnosis behind this vomiting. So we cannot say that vomiting are so many causes. So we will have to see what is the reason Sam is developing this throwing out episodes. So according to that, we can prescribe the medicine. But you should tell your GP that Sam is having epilepsy. So he will be careful that he will not prescribe this medicine anymore.
Simple, we can say also we can make a meeting with our consultant regarding this issue.
Yeah, this one can be addressed like this also. So we cannot give a proper, I don't think so. We will find even in the Google. I don't think so. This is very difficult to find out these kind of things.
Okay.
So
mainly here it was we should know about the extrapyramidal side effect of metaclopromide. That's it here.
yes,
And also the aggravation of epilepsy.
Yes, that was actually the scenario. So in the scenario, we will have to tell that this may be the unwanted effects from these drugs, that maybe we will have to memorize. These are the side effects like the shaking of the legs or arms, or extra muscle movements, or lip smacking, and uh, twitching of the lips, or twitching of the tongues. So these are the side effects. So we will have to tell that, and we will have to tell the red flags, which I have told already. We will have to tell the advice. This may be the scenario is like this. I think so.
Advice also are about they may have excessive sleepiness. So
Yes.
for older people, they should take care of driving or using any mechanical issues. Even children at school, if they have any practical classes, they can take care like this.
Yes.
They can inform also, or they can take a leave from the school like this.
Yes.
Okay. So
Okay,
we will go to the next scenario.
I will give the scenario.
Yeah, no problem.
You can share the video, not me, not mine. You have one video. This is the second scenario which I could not find. So you can give that video.
Okay.
And who is going to do?
Problem. Let Dr. Yasser do this. Okay.
Okay.
I will share that, just 1 minute.
So this is a 12 years old John. See the video and give you a description.
Okay, I will play it now. There's no sound in the video, okay?
No problem.
The video was for 2 minutes 51 seconds. So after 10 seconds, we'll.
Can I describe?
Okay.
Wait,
Okay.
Fix the time.
Okay, you can start now.
I have seen a young boy laying comfortably in a bed, having in a hospital setting, having branula on the left hand. A medical professional examining the lower limb of the patient who has generalized muscle atrophy bilaterally, having hypotonia, hyporeflexia, and power of 0/5 in the lower limb. And his plantar was down equivocal, and his clonus is
Okay. What history question would you like to ask?
I will ask him regarding the previous episode, onset, duration, any aggravating and relieving factor, any history of fever, sore throat, cough, any loose stool, and any source of infection, and any drugs, just like alcohol, and history of trauma, and any bowel or bladder incontinence, and any bad sore.
Okay, so what examination would you like to do?
I want to do a full neurological examination.
Okay.
Involving the upper limb, cranial nerves, and cranial nerves involving the eyes especially, and the tongue, and the posterior vocal cord, and the posterior pharynx. And I want to check the respiratory movements, and respiratory rate, heart rate, and blood pressure. And also for
Okay.
abdomen, for bowel or bladder incontinence, any mass is palpable.
What is your differential diagnosis?
It could be a case of a Guillain-Barré syndrome. It could be a case of hereditary motor sensory neuropathy, or it could be a case of drug-induced peripheral neuropathy.
Okay. So, what investigation would you like to do?
I want to do, first of all, CSF to see the albuminocytosis dissociation, albuminocytological dissociation. Second thing, I want to do nerve conduction study and electromyogram, and also want to do CK level. Then I want to do spirometry, ECG, blood pressure monitoring,
Okay.
and stool analysis for,
Okay.
and MRI spine to see
How will
the
you manage?
I will, the patient needs admission because this is acute paralysis. First, second thing, I have to involve my consultant. I have to take a history, and then I will involve a multidisciplinary team, including my consultant, neurologist, and intensivist, physiotherapy, occupational physiotherapist.
Okay.
And
Okay. What else you want to do?
I will give him, I give him immunoglobulins, and if not responding, then I will proceed by plasma exchange. I will give start supportive treatment along with the management of pain and pain and with the deep venous thrombosis prophylaxis, and I will
What will be the for deep vein thrombosis prophylaxis?
enoxaparin we can use, heparin or enoxaparin. Low molecular weight heparin we can
So
use, or strokings
what
you
is
can
the
use.
prognosis? What is the prognosis?
Prognosis is guarded. Out of 7 to 8 patients fully recover in 6 to 12 months, but some will develop muscle weakness, limb weakness, muscle atrophy, and some develop respiratory compromise.
What are the poor prognostic factors?
Poor prognosis is the rapid onset of progression of the disease involving the bulbar involvement and respiratory involvement, and not responding to the treatment.
Okay. So what may be the complications they may have?
They will develop a swelling problem. They have a chest problem, infections, and autonomic instability.
Okay. Okay. You have finished your. Okay, I will give the feedback now. Time finish. So, Dr. Yasser, that description was okay, but I don't know, power was zero completely, or maybe I think one.
He is not moving his limb, but
No, he's flickering. If he asked to move,
Flickering was
you
there.
see,
Yeah, flickering was there.
to
Which I have.
observe here, after everything he has to move himself. He's just moving on the bed, not against the resistance, but you
Yeah,
see,
see this one. See this one.
no, he's not against the gravity. He's not moving against the
yeah,
gravity.
moving against the gravity will be
No, this is
3/5.
flickering. This is flickering is there. So flickering
2
means
by
2.
5.
2
At
by
least
5.
2 by 5.
The flickering is not that one we tap and then we can see the muscle. The
No,
flickering
check
that I
again.
know from
Check.
my graduation.
Dr. Noor, show this one flickering again, which we are saying.
Yeah, he's moving his limbs.
Yeah, this is we called flickering, na?
Okay, because
Flickering.
before my knowledge is
doing in the beginning, no? What is that, Dr. Adnan? The tapping he was doing in the beginning. That is for grade 1.
Yeah, if completely not moving, that will be 0. Okay. Then 1 is coming if with tapering, if you are tapering and some flickering movements are coming, then will be 1. If he's moving by himself, which I have seen this here, so that will be 2.
Yeah.
But on the bed. But
It
on
is
the
very
bed.
clear here. If he asks to move, he is moving. You see, not against the gravity, but on the bed he can move.
You can say he has grade 1 only power.
See, left side, he's moving by himself without doing flickering. Yeah, tapping. So this will be 2 by 5. One thing, differential, Dr. Yasser, I will tell you, better to take the differential here is a good thing. Is first one is okay, that was the diagnosis, Guillain-Barré syndrome. Second, you should keep transverse myelitis or cord compression and poliomyelitis, so that you can negate by yourself that poliomyelitis usually in the one side and transverse myelitis will be acute. So I don't know about the history as well. And again, the cord compression can be keep, that will be more beneficial for the exam purpose. And you have keepin this what was you have kept?
I put this one
Charcot
Mary and
Charcot is not,
drug.
no, Charcot is not coming here. Charcot patients are moving. Charcot patients power is not like this. They have distal power reduced, but not like this. The third thing is no muscle wasting is completely up to the upper thigh. Here is the see muscle wasting up to the upper thigh is there, but in Charcot there will be of champagne inverted champagne bottle like weakness will be there. So distal muscle weakness will be there, or distal muscle atrophy will be there, but not the whole legs. So this is not a good choice, I think so. In the history, you have asked each and everything. So better way is like we are starting always onset, course, duration, progression, and if this is symmetrical or asymmetrical, which I can see this is symmetrical, and the previous history of any upper respiratory tract or gastrointestinal infections, and would like to ask the history about the associations. What may be the association? Involvement of the respiratory, involvement of the heart, and throwing out episodes, and headache. So we should keep SOL also should be ruled out. So history of trauma, history of the drug intake, which you have already, and family history. Okay, no problem. You can ask that one also. So as a history of association is very important here. Like headache, vomiting, difficulty swallowing, respiratory problems, palpitations, because they have autonomic problems that can be lead to the arrhythmias or instability in the blood pressure, hypo or hypertension, both can be occurred. So that will be a good way to for the history, I think so. So in the labs examination, you have told very nicely, complete CNS examination, including the cranial nerves. And then again, you will have to do the general physical examination with the respiratory and cardiovascular examination, and definitely spirometry and the vitals, which you have told. So labs, CSF, okay, and antibody screen that can be done in the stool. Spirometry you have told, ECG you have told, nerve conduction study. EMG there is no role in if you are keeping this GBS, so there will be no role of EMG. One more thing, serum electrolytes never forget, because one of the uh, side effects of this SIADH can be occurred in GBS. So that should be management. That was okay. Multidisciplinary team, that was really good. Even that was not in my mind, I will tell about the multi, but always start, because this is a GBS, this is a emergency. So always start that. I would like to start to check for airway, breathing, circulation, because that can be involved in GBS. Instability can be there, hypotension can be there, and arrhythmias can be there, breathing problems. So always start with airway, breathing, circulation. Then already child is admit. So I will start with sportive cares, that will be passing of NG tube and passing of Foley's. And if the child is in shock or is severe hypotension, will consider of given the crystalloid and will involve my consultant. And then start with multidisciplinary approach, like you want to involve the neurologist, you want to involve the occupational physiotherapist. That will be, yeah, that will be a good way to tell the about the management. And my management will be a plasma phrase, plasma exchange, and IVIG, and prophylaxis for the DVT and pain relief. So this will be prognosis. You have told that that is, I just to memorize, 20% they may have neurological problems persist, 20% cannot walk unaided. So 20 is the figure for the GBS to memorize, and mortality is 3 to 7%. Okay, prognosis, poor prognostic factor, one is rapid progression, and there is no improvement after the 2 weeks. So this is the main advanced age, poor nerve conduction uh, studies, that is showing the poor, mean to say this is too much involvement is there. And if the child is on the which you have told, that respiratory complications, respiratory complications like pneumonias, they may have aspiration pneumonias, they may have respiratory failure, unstable blood pressures, arrhythmias, they may have psychiatric problems, residual problems after that. They may have bladder problem like urinary retention, or persistent paralysis can even be continued. So these are the complications from my side. Dr. Noor, you can add if you want.
Cardiac arrhythmias, I think you told already.
Yeah, arrhythmias, yeah, I told earlier.
Can you tell about this 20% again, the prognosis?
Yeah, prognosis is 20%. They may have this paralysis persist, and 20% no, 20% they may have residual problems. Out of them, 10% they may have persist this paralysis. Persistence of paralysis they may have out of 20%. That will be severely disabled. I mean, so mortality is 3 to 7%.
Okay, 20% will have residual paralysis. Mortality will be 3 to 7%. More than that,
Yeah.
we can say that early treatment is means early recognition of the symptoms and treatment also for the better
Yeah,
prognosis. And if
better prognosis.
weakness lasts, if the weakness lasts more than 2 weeks, it is not good prognosis.
Yes, this is the main. If the weakness lasts more than 2 weeks and there is no improvement, this is the very bad prognosis.
And what about the IVIG? When do we start? As
IVIG, we should start as soon as early, but even within 2 weeks we can start. If the child is coming after for example 10 days, and you are thinking that this is GBS and you want to start IVIG, you can start within 2 weeks. You can start, no problem.
Okay, I think usually they will give 2 doses of IVIG.
Yes.
If it does not respond to first dose, they will repeat the second, right? And
Yeah, second dose can be given in GBS. In the Kawasaki, which we are telling, usually we are giving the 1 dose only. We are not usually repeating, but in GBS can be repeat second dose.
yeah, second dose can be repeated. And if this fails, then they will consider this plasmapheresis.
Yes.
Okay. Okay, I think enough. We can go to the next case.
Okay. Before yesterday, I have studied today. This pain is very difficult thing.
Can I give my case? I have to go some.
Can you repeat again? I cannot see properly. What is this? Repeat once again. So what is the age and
Dr. Yasser, please give the age and the name.
Yeah, this 3-month-old John.
3 months old John? Okay.
Okay, I'll keep the time.
Oh, okay. So I can see a well-looking child lying on the bed comfortably, most probably in the home setting. And there is nothing in the surrounding which I can appreciate, and there is nothing on the body which I can appreciate like IV cannula or anything. or any unusual features. All of a sudden, there is some movements of the hand and arching of the back, which I have seen in the video. Okay.
Okay, what will be what history you want to ask?
So first of all, I would like to ask the onset, course, duration, progression, any triggering factors, or any associations of any epilepsy before, or any throwing up episodes, vomiting, and also would like to ask the past medical history and the birth history regarding his specific for the birth asphyxia or any history of trauma, head injury, and history of family history. Would like to ask about any genetic condition in the family or any neurocutaneous syndromic history in the family. All these things would like to ask.
Okay, what examination you want to do?
So examination, first of all, I would like to take the vitals, and then I would like to do the general physical examination, including the skin, and then will be examination of the CNS examination, as including the cranial nerves, and eye examination, and as well as the abdominal examination, especially for the palpation of the kidneys.
Okay, what will be your diagnosis?
So I will keep the differential diagnosis, like it may be of infantile spasm, or it may be of benign myoclonic epilepsy of infancy, or it may be of abdominal colic, that Sandifer syndrome.
Okay, and how will you investigate?
So the investigation, after doing my complete neurological examination and taking the history and doing the vitals, I would like to go for EEG. And if it is infantile spasms, I would like to see for hips arrhythmia, and will consider for CT and MRI as well. So, and other investigation will be according to my diagnosis.
How
um,
will you manage this child?
So after taking the history from the mother, I would like to involve multidisciplinary team as well. And as the child is currently is that can be due to benign myoclonic epilepsy, so would like to check on the bedside for the BSR as well. So multidisciplinary team will be like a pediatrician and a neurologist, and associations, if it is, that is very less likely if it is associated with tuberous sclerosis. So that will be like ophthalmologist and cardiologist, pulmonologist, nephrologist, and dermatologist, and occupational therapist, and physiotherapist, as well as community pediatrician, and to join all this, and social worker. And this is my multidisciplinary team, and education of the parents as well. And to control this infantile spasm, if it is tuberous sclerosis, then I would like to start the vigabatrin, and would like to tell about the unwanted effects of the vigabatrin to the mothers, give the red flags if there is any problem with the eyes, or uh, they should be in follow up with the ophthalmologist and optometrist also, if vigabatrin. If it is not tuberous sclerosis, so the drug of choice will be steroids like prednisolone can be given, or adrenocorticotropic hormone can be given.
What is West syndrome?
West syndrome, there can be of infantile spasm, and I don't remember this one. There is one another thing,
It's,
learning difficulties or something.
it
You
is a
mentioned
triad. It is a triad of infantile spasm, mental
And
retardation,
yeah,
and
mental learning difficulty, and what else?
there's one more.
Arrhythmia.
Hips,
Ah,
huh?
hypothermia, yes.
Hips arrhythmia, yes, yes.
EEG finding.
EEG finding.
EEG finding, yeah.
Okay, Alhamdulillah, you did well. But the only issue, sorry, this I was thinking this video was good, but when I observe now, it's not a good quality. Sorry, really
Yeah,
sorry.
that was not a good. That's why I
I choose
kept
another one, but
benign
when
myoclonic.
I see I like it look like, but now well, maybe I was in a hurry that when I saw it. But okay, everything is fine. But as you know, 30% are idiopathic and 25% are due to tuberous sclerosis.
Your voice got.
As
Yes, yeah.
yeah, 30% idiopathic and 25% tuberous sclerosis, na? But you did not mention
Yes.
any investigation for tuberous sclerosis.
Yeah, this one is time was running. I told you according to my diagnosis further for the association, I will do the investigation. I can, yeah, I should mention about the genetic study, and I should mention about the associated like the RFTs should be done, ECG or echocardiography should be done, and
Yeah, no,
again
no,
the
okay, khalas. For but wood lamp examination for skin, this
yeah,
actually,
yeah, I was coming to that wood lamp examination of the skin and CT MRI, which I have told already.
and you know, the most common cause is congenital infection like torch and severe hypoglycemia.
Yeah, that's why I given about birth history. Would like to
Mhm.
ask about the birth history and would like to check for the BSR
Yeah, that's also. Okay. And what are the associations?
with the tuberous sclerosis.
And with this infantile spasm, yeah, just like you, just like we have intellectual disability, mental retardation, delayed motor milestones, so they are
Yeah,
associated with
that
this.
that can be associated. Yes, okay.
Yeah. This is also an emergency. Also, you know,
Yeah,
infantile spasm is also an emergency.
I don't think so. This we should ask about the very small child about the medicine past medical history. I asked last meal and allergy. We should ask our hair or not.
No.
Ample.
Here, no. In such small children, no.
Yeah, this one I was thinking we should not
Just
ask.
like in status or something, here where we can, but here no need. I think so.
Yes.
Okay,
Okay.
1 minute.
Yeah, that video was yeah, that video was actually looking like myoclonic epilepsy, benign myoclonic epilepsy, because there was movement. This one is very fine. This one, see, yeah, this is very good video.
Means
It's
there is
clearly
flexion
showing.
of the neck, flexion of the extension and fanning out of the limbs, and flexion of the lower limbs. Upper limbs are getting, there is in the upper limbs there is extension, right?
Yes, you will describe that there is extension of the over limbs and this upper limbs, and the flexion of the lower limbs and arching of the back.
And
All of
also
a
neck
sudden,
is flexing. You see here, there is
neck
flexion.
is flexing. So this is a kind of infantile spasm.
Means this
But
is
you
like
know,
mixed. This is
but we
mixed.
should be prepared for like previous video. Now in on 29, I don't know 29 or 28th, which has in UK, they have given not that was not clearly infantile spasm. That was very difficult.
No, it will be a case of differential diagnosis, like as you said, benign myoclonic epilepsy.
Yes.
So here the description will be there is extension and abduction of the upper limbs, okay, and flexion of the neck and flexion of the lower limbs. So this is like mixed, both flexion and extension actions are here.
Yes.
You see, flexion and abduction of the upper limbs, and also neck flexing is there, arching of the back is there, and flexion of the lower limbs.
Yes.
Okay. Okay, I will stop now.
Okay.
So what's the next now?
If you want to do, okay, I will give you, or Dr. Yasser, if he want to go, he can go now, or he can
You
do
want
one.
to go, Dr. Yasser? So this case for me?
Yeah.
Okay. So I will play now and Dr. Adnan will keep the time for 3 minutes or 2
Okay,
minutes, no problem.
Got the best rash you guys have seen in a long time. I wonder if you can guess what. How are you?
About,
Hi.
I don't know, about a
What you
month or so
doing?
ago.
What you doing?
And then,
So this all started how long ago?
this started like Thursday.
Today's Monday.
Yeah, last week.
So Friday, Saturday, Sunday, Monday, 4 days ago. And it started probably with a few little red dots.
Yeah, mostly on his head.
Mostly on his head. And then some of these dots would get fluid in them.
Yeah.
And then they're probably itchy.
Yeah.
And you scratch them and they get crusted over. So this is just, he's covered in these lesions. The characteristic of what we're seeing here is tiny little red dots. And then you get some with fluid in them. And then they'll crust over, like you can see up on the scalp here. Those lesions. Maybe we can just show a few on this bottom to show that when they get at their worst. So you can get some that get kind of purplish looking. We call that hemorrhagic. Just for the camera, people are really worried that I washed my hands before I came in here, and I'm touching this rash, you guys. Oh my goodness. So I'll go ahead and tell you what this is. You probably knew. You guessed it. This is chickenpox. The hallmark of chickenpox is having lesions in all 3 stages: little red dots, fluid-filled lesions, and crusted over lesions. When the final one crusts over, then you're no longer contagious. So you're usually contagious for about a week with a crop of new lesions coming on board.
Okay, you are ready?
I think we can start.
Okay.
Give me the name,
Start.
name and the age.
John and 1 year old. 6 months. 6 month John.
1 year old. Okay, 1 minute. Just when I start.
Okay, no problem.
Okay, you can start now. I will wash my. Okay, in this video, I can see a small 1 year old child who is in with the mother in a clinic where he's being examined by the doctor. I can see that he has a rash all over his body and in some places it is just red papules, and in some places vesicles, and in some places crusting is seen. The rash is being consistent with chicken pox. Otherwise, the child is looks well active, not in distress. Okay, so I want to take the history of in this child about the onset, duration, and progression of this rash, and about the fever. And anyone has the similar condition? I mean, did he got contact from anyone? And if he is on any medications like steroids? And also I want to ask about any respiratory symptoms he has, like cough, SOB, and also his activity and the feeding.
Okay.
Okay.
So what examination you will do?
So the examination here, I will do the complete head to toe examination of the child to see the rash and the different stages of the rash. And also I want to examine his throat for any congestion and ears, as well as his chest for any shortness of breath, distress for any signs. And also I want to do the CNS examination to rule out any features of meningitis and encephalitis. Then my differential diagnosis here will be chicken pox. And also I want to consider herpes simplex, less likely due to the distribution of the rash, and also herpes zoster. Then investigations.
Yes, what investigation like?
Usually this will be a clinical diagnosis mainly, but sometimes we can send the scrapings of the lesions to do the PCR testing, and also to see the immunohistochemistry of the lesion.
Okay, so how will you manage this child?
Yeah, as long as the child is well looking, is not immunocompromised, his immunity is good, he can be just, we can wait and watch for him by just antipyretics, analgesics, good hydration, and supportive treatment. But if the rash presents before 24 hours, you can consider for acyclovir. And also if the rash becomes too much progressive, and also if we have fear of complications like encephalitis or pneumonia, we can consider acyclovir in these children, and also especially in immunocompromised children as well.
Okay, so what may be the complications associated with
Pneumonia? The pneumonia can be some viral pneumonia, can be sometimes life-threatening in these patients, presenting with wheezing, shortness of breath, and also encephalitis can also be life-threatening, requiring the ICU admission and monitoring, and IV acyclovir.
One you told pneumonia and
Encephalitis.
Encephalitis. This is the okay. What may be the long-term complication?
Long-term complications, they may develop later herpes zoster and post-herpetic neuralgia.
Yes.
And in the treatment, we can also consider for antihistamines if there is too much itching, and emollients.
Yes, which you have forgot before. Emollients can be given, but nowadays calamine lotion they are not using.
Not recommended. Yeah.
Not yeah. Before they were using antihistamine like chlorpheniramine or pyritone that can be used. And two things left which you advise to the mother. The one is remove the fingernails.
I will tell, wait. Prevent contacts with prevent the contact of the child with the neonates, pregnant women, and also the immunocompromised children.
Yes, very good. What else?
And also to check the immune status of the other contacts.
And cut the fingernails of the child, nails of the child, and dress her or him very comfortable.
Cotton
Like
dresses, light cotton dresses.
yeah, like cool smoothie fabrics we are using.
Mm.
Okay, this is and you told about the extra fluid should be given, good hydration,
Good hydration, yeah.
and should not use this brufen or
Yeah,
other things.
only paracetamol should be used. Brufen can cause, what is the side effect it can cause? Necrotizing fasciitis.
Yes, time is over now. Necrotizing fasciitis, or they may cause thrombocytopenia in these childs. So bleeding can be happen. So mainly you have done nicely, very nicely. There is no comment, I think so. But when you are describing, just say that I can see a rash all over the body, even involving the scalp of different ages, like different ages or different stages, whatever you want to pronounce the word.
Yeah,
Or like
different
I can
ages
see the
important.
pustules, I
Mm.
can see the pustules, I can see the vesicles, I can see crusting over lesions are also there. So like this will be a good way.
Mm.
And the child is in the lap of the mother. So this is like whenever you are starting there, well looking child, 6 months old well looking child in the lap of the mother, and probably in the hospital setting, but I cannot see in the surrounding or any monitor is attached to it, or any IV cannula is there, and nothing is in the surrounding has been shown to me. So I can see there are rash of different stages, which involving the whole of the body, even in the scalp. And the description of the rash is I can see the vesicular rash, papules, and pustules, and crusting over lesions as well. So like this will be
Mm.
description, because your description was okay, but you have finished maybe 3.5 minutes. Then I asked you about the complications and other things. So just to give the more description, that will be good. And for the management, always this is
No,
after
wait. For the differential diagnosis, what we will give here?
differential better is uh, measles we can keep, but this rashes not look like measles. We can keep this which you have told this
Herpes simplex.
yeah, that can
Herpes.
be.
Okay, but so all we have to negate, like this is very clear case of chicken
Yeah,
pox. Herpes
yes.
simplex, usually it will be around mouth or around the genitalia.
One more thing,
And,
yeah, which I was telling, I was thinking now I remember, hand, foot, mouth disease is also coming like this. The same
yeah,
description that can be kept
can
in
give, yeah, hand, foot, mouth disease
differential.
we can keep. And also this, then herpes simplex, then herpes zoster at the last, and say that
Yes,
herpes zoster will be in a particular dermatome.
yes.
Yeah, and this case, just to, okay, you give your feedback, then I will tell. Just finish.
No, you have done nicely. It's not just I'm adding feedback. I don't think so. You have done nicely. Just like when you are giving the management, so tell that I would like to ask the history, and after taking the history, we'll check for the vitals, like heart rate, respiratory rate, and blood pressure. Respiratory rate is very important here. So after doing this, I will inform to the consultant, and this is notifiable disease or not, I don't know. So if it is notifiable disease, then you'll have to tell the this where we are notifying the CDC. What is full form? I don't know, I forget this one.
There are
So
two CDCs here. One is Center for Disease Control maybe, another is the Child Development Center. 2 CDCs will come.
No, not child development. That is a controlled disease. I mean to say.
No, that is what I'm telling. For CDC, we should remember 2 things.
Yeah.
In developmental cases, we say Child Developmental Center, and here maybe what I said.
Child disease control, something.
But we have to check. We have to check. We cannot just.
So this is notifiable or not? I don't know.
No
Maybe
problem.
notifiable.
Let's check.
So you will have to tell that I will notify.
Yes, it is. Sorry, it is notifiable. This is CDC. You have to notify.
Yeah, that's good. So you will have to tell that this is. I would like to notify to the public health center, and will involve my consultant. And after that, I will educate the parents about the disease, its complications, and its prognosis, progression, complication, and prognosis. Then I will advise to the parents, like you have told, that if anybody is in the family is pregnant, he should avoid to contact with the child. If any small child or any child with immunocompromised child, or child is on the drugs like medicines like steroids, or on the immunosuppressant drugs, he should be avoided from this. And any child, and then I will advise the parents to cut the nails of the finger and give the good.
Yeah. And regarding the vaccination of the varicella, usually it is not routinely vaccinated for all children. In UK, the children will get the infection from the environment usually and develop the immunity. But when do we consider vaccination? They can ask this question.
Yes. So these are the education of the parents, advice to the parents, and when they should come back, red flags. So whenever we don't have a good management plan, like we cannot tell, so we'll have to go like this. We'll have to tell about the what is education of the parents, what is the advice, what is the red flags. These are the 3 things which we have to tell when he should come back. And what may be the complication? Complications can be acute complications. Acute complication involvement of the brain, that can be encephalitis, that can be of post-varicella encephalitis, post-varicella cerebellitis, and that can be involvement of the lungs. So pneumonias can be there, involvement of the pancreas, pancreatitis, involvement of the kidneys, inflammation of the kidneys can be there. These are the complications which are the acute complications, and child may develop the dehydration. So for that, I will advise to the parents good oral hygiene as well.
Hydration.
Okay. Yeah, good oral hydration. And long-term complication, as you told, this can this virus can be
dormant in the nerve roots.
Yeah, stay in the nerve roots, and it can come back in the in the later on in the adult life when there is reduced immunity, and it can cause the shingles in the dermatomes. Okay.
And also whenever the child is immunocompromised, it can also cause herpes zoster.
Yes.
And maybe it can also reactivate when they are on steroids or immunocompromised drugs.
Yeah, one more complications, I think it can lead to the acute otitis media, I think so, which I remember.
That's why I told also, no, I will examine the throat and ear, and all examination, like how we examine a febrile child, should be done in these patients.
Yes. So this is all.
Okay. So you said about the parent, for the parents, education of parents, red flags, and what else you said? Explanation to the parents.
First one is always education of the parents about the disease, progression, complication, and prognosis. Then you will have to tell that I would like to tell about the advice to the parents. Advice here is cutting off the fingernails, cutting off this, using the loose clothes and cool clothes, not too much cool, but cool clothes, and this one further is about the red flags. So red flags, if the child anytime is develop vomiting, especially vomiting or any drowsiness or not feeding properly, and any difficulty in breathing, they should come back. So these are the complications. Any tummy pain also, these are the red flags when they should come back.
And
And
also the SOB for the chest.
yes, so shortness of breath, definitely. So if then I will give the some antihistamine to relieve for the itching, and some giving to the soothing effect with the emollients
And paracetamol.
and paracetamol.
And we should always tell when do we consider acyclovir.
And yeah, good oral hydration and acyclovir. Acyclovir we are giving when?
In the patient info, it has written if presents within 24 hours and has severe chicken pox, and if they are at risk of complications.
This one I was telling to someone before, I don't remember when it is, before maybe 3-4 months or so. They are telling that there is no medicine in the NICE guidelines. They have written no need of acyclovir.
Yeah. So tell usually, that's why I told in this way. In an immunocompetent child, just supportive treatment, tell like this. As long as you're sure that the child is immunocompetent, means he is not on steroids, he's not on immunocompromised drugs, and he's not a known case of immune deficiency. Immune deficiency child, definitely you will know with repeated visits of infections, right?
Yes.
So as long as the child is immunocompetent, it needs just supportive treatment in the form of good hydration, analgesics, only paracetamol, avoid NSAIDs, and observe the child. And when do you consider acyclovir? If there is child has severe chickenpox infection, or if there is fear of complications, and in immunocompromised children. You can tell, but less than 24 hours it is written, but we will tell or not, even this is my doubt. It is given in patient info. Presents, if presents within 24 hours, you can consider like this.
Okay. Dr. Rihanna, would you like to do one video? Are you busy?
I'm in ICU, sorry.
Okay, no problem. I will do the next one. We will finish off with the Yasser. I don't know, maybe I have to give one video to Yasser, or Dr. Yasser, how many cases you did now?
Dr. Yasser is not here. So
I
you
think
can
he's not there. He put a
we'll have
message.
to-
No problem, we
we'll
both
have to
can do.
make-
Wait, you give me the video next.
I have given you already in the.
Okay, I will share now.
Yeah, this is good blood gas. Can I?
Okay, I shared the video. Now I will play. Okay, you will keep the time, huh?
Okay, no problem.
Now we're moving.
Dr. Noor, leave this one part. Just in the beginning you can see, okay? Because I could not find any video, so that's why I played this one. In the beginning you can see only. If you want to comment that one also, no problem.
What is the age of the child?
10 years old.
Hello?
Yeah, 10 years old.
Okay, now I was not hearing. Can you tell the age of the child?
You cannot hear me? Hello?
Now I can hear you. Tell me the age.
Yeah, 10 years.
10 years old. Her name?
Camila.
Tamila?
Yeah, Camila.
Camila. Okay, 10 years old, Camila. Okay, so I will start. Okay. In the video, I can see a 10-year-old girl, Camila. She is in a hospital setting. She is attached to the monitor, cardiorespiratory monitor, and there is a nasal cannula and also chest leads, and also there is an IV cannulation in her right hand. I can see that there are some jerky movements in her upper limbs and the lower limbs, and also there is upward rolling of her eyes, and it is continuing. It is continuing as long as I saw in the video, and there is no regain of consciousness in between.
Okay, what was that jerky moments? Can you describe that?
Clonic.
Okay, that was generalized tonic-clonic. Okay.
Generalized tonic-clonic. Okay.
Yes. What history would you like to ask?
Yes, in this child, I want to ask about any triggers before onset of this seizure, and any aura this child developed before the seizure, and also the onset, how it started, progression, and how long it lasted, and the end of the scenario from the witness. And also I want to ask about the child had any history of headache, vomiting, any behavioral issues, or any weight loss. And also I want to ask about any history of trauma and any fever, any excessive sleepiness, reduced activity. And I want to ask about any skin depigmentation or hyperpigmentation, any developmental delay, and also about any chronic conditions she had before, like
Drug
metabolic,
intoxication. Yeah,
and
drug
also any past history of similar conditions and drugs and alcohol.
Okay, so what in examination would you like to do here?
Here, I want to first, after stabilizing the child to come out of her seizure, I want to do the complete CNS examination for tone, power, reflex, coordination, sensation, to look for the neurological deficits, and also the cranial nerve examination. And I want to do the skin examination in this child.
Okay, and vitals also, pupils,
Vitals.
and oxygen. This one. So
CNS.
what is your differential diagnosis?
My differential diagnosis is this child may be in status epilepticus, because the seizure did not abort till I saw in the video, and she's not conscious, and uprolling of eye is constant. And also I want to consider maybe just generalized tonic-clonic seizure.
So your differential will be here, seizures associated with the different causes like head trauma, meningitis or encephalitis, febrile convulsions, SOL, cardiovascular accident, or electrolytes imbalance. Like this you will tell.
Okay.
Okay, then how will you investigate the child?
Yes, this child, since this child is unstable, I want to do the bedside blood glucose and complete vital signs, including blood pressure and fundoscopy for this child, and do the CBC, urea electrolytes, blood gases, blood lactate. And I also want to consider imaging in this child, that is MRI and EEG.
Okay, and septic workup also, because she is very sick.
Yeah,
so all this septic workup to rule out for any meningitis, encephalitis, and toxicology screen, don't forget.
Okay, CBC, CRP, blood culture, and toxicology screen. Okay.
Yeah, toxicology screen and the metabolic screen for the ammonia, lactate, and organic acid or amino acids. Okay. So always in the epilepsy, we should be complete septic workup with CSF, metabolic screen and toxicology screen. That should be done.
Septic work, including the CSF.
Others, as you told, others as you told, electrolytes and ABGs and LFTs, glucose and others. So how will you manage this child?
Yes, this child needs urgent attention to airway, breathing, circulation, and I want to start her on the high flow oxygen. Then check the blood glucose and consider for the anti-epileptic medications like lorazepam. She's in hospital setting, so I'll start with lorazepam 0.1 mg per kg IV. Then if there is no response in 10 minutes, then I will give second dose of lorazepam 0.1 mg per kg IV.
If it's not improved,
then I will consider phenytoin or phenobarbital in this child. If then after that, I will wait for 20 minutes. Still, if child is not improved, I will involve the pediatric intensivist and consider for rapid sequence induction with thiopentol.
Okay.
With intubation, right? Rapid sequence induction with intubation.
Yeah, that's okay. completely you have done. Just if the child is in shock, you will give the crystallide also.
Okay.
And if the epilepsy, and the other treatment will be the cause of the epilepsy. Like maybe he's having meningitis, encephalitis. According to that, he may need, she may
According to
need
the
antibiotics.
cause, yeah, according to the
Mhm.
cause, I will give her if it is meningitis, IV antibiotics.
If
Okay.
encephalitis, that should can be due to viral, so antiviral, we'll consider the antiviral also.
Meningitis.
Okay, and if in, yeah, if in shock, normal saline you can give
Okay, and
crystallide.
if it is trauma and there is any bleeding, we will involve the neurosurgeon.
Yeah.
I have to also tell here in the how do you manage this child after managing the ABC, oxygen and glucose. I will involve my consultant. Very important here.
Yes.
I will involve my
Yes.
consultant, then give all these medication. Then you will involve the neurologist, and also in cases of trauma, we may need neurosurgeon.
Yes. This is the thing.
Yeah, and also in sometimes in meningoencephalitis,
In
also involve the
in
infection specialist
yeah,
and pediatric intensivist. These are the roles who will come here.
yes. Whenever there is any emergency, like we are starting airway, breathing, circulation, just give one uh, description, like I look airway for the potency of the airway, and breathing for the effort of the breathing is there or not, and the circulation like heart rate, and capillary refill time, and the blood pressure. So that will be good.
Yeah,
You are doing the
and her
description.
heart rate also was very high. I can see only heart rate
Yeah,
190.
that was actually SVT. So that's why I
Mhm.
told you don't go to the SVT. That was in the, if you will see again, that is
Mhm.
showing completely SVT.
Yeah, but I did
ECG
not
finding
observe the
that.
ECG. I just observed the heart rate and
Yeah, yeah.
no, but what was the case here actually? But for me, the tonic of movements of the whole hand were not clear. Means was the whole body means it
Almost
was.
whole body was there because she was lying, so that's why you cannot say properly generalized tonic-clonic. But if the child, if anybody is lying and he's having this generalized tonic-clonic, this will become like this.
Usually the absence will be the child will be standing, and even the myoclonic they may be sitting, and only just one group of the muscles will be jerking, right? So like this presentation usually by generalized tonic-clonic seizures.
Yeah.
Can this like other seizures can present, other general seizures can present with status epilepticus?
Yes.
My doubt,
And
like
any almost
absence
any,
can present.
yeah. Yes, they can present. Usually they are not presenting with the, but any epilepsy can leads to the status epilepticus.
Means absence, myoclonic jerks, they all can present as the status epilepticus.
Which I know, yes, they can present, but needs to confirm better.
Yeah, and
They,
also about the loss of consciousness is very important here. If the child is conscious,
yeah,
many times what happens in myoclonic jerks, they can be conscious. They are conscious. They're just only a few group of muscles is jerking. So as long as they are conscious, it cannot be considered as status epilepticus. So common, I think GTCS is the one which will present with this commonly.
yes.
Okay. Anyways, so there is one more thing I think we should know something about, when the child enters the post-ictal phase, how do you manage the child?
Post-ictal phase, they are doing nothing, just few things. One is like they should kept in the recovery phase.
Yes.
Okay, this is the one thing. And if the child is already on lost of consciousness, so we should not interrupt, should not put anything in the mouth. And after that, when he has recovered, they may have some tiredness or something, sleepiness. So we should advise them to take some rest. That will be better.
Okay.
And if they will ask you what advice you will give to the mother, so the same advice whenever the child is having this kind of events, so they should immediately call to the emergency. They can, if they are having this in the kit, midazolam, they can use that one. Child should be in the place of recovery place, recovery position should be kept. Don't put anything in the mouth. Don't start any, if they have lost the consciousness, don't start CPR. And
Yeah, I will tell you a few things.
after
Actually,
yeah, triggers should be avoided.
yeah, trigger should be added. Here,
Compliance
what
to,
happens is every child should have epilepsy action plan with them. Epilepsy action plan card or the bracelet, whatever they should have with them always. Epilepsy action card or a bracelet on their hand or something, so that when they are in attack, someone can remove it and see what is their problem and how they can help. Even if no one knows about him, can know about him. Okay. So they should have epilepsy action card and this with them, writing about the medication they are taking, the dose they are taking, and whenever they have an attack, what emergency action should be taken on them. So everything will be written in that card. Then the mother, the school teacher, the school nurse, and anyone who is around her will be taught like to use the buccal midazolam or rectal diazepam, whatever. In case of emergency, they should know, including the ambulance crew. Okay.
yes,
And whenever they come to the hospital, if they have received first dose, then you will give only the second dose of benzodiazepine. If not improved, you will next go to the phenytoin or phenobarbital. Okay. This is one thing. Regarding the management, always whenever the child has, suppose this is a case of generalized tonic-clonic convulsion, whenever the child is in convulsion, you will just see that the scene is safe for the child. Anything which can hurt, you will remove from that and give the support to the head with some cloth or pillow. Okay. Give the support and see to it that nothing is there in the mouth, or you will not put the airway is clear.
Yes.
Then till the child is in what is that, seizure, you will not move the child. Whatever they are in supine, they will be in supine only.
Yes. After that, it will be in the
after
recovery.
that, we will put them in the left lateral position.
Left lateral position.
So when they are seizing, just your job is to only remove anything which can hurt them around them. And the second thing is give some support below the head so that they will not have any head injury. See to it that the airway is open.
Yes. One more thing, count the timing also.
Yeah, timing. Watch for the timing. And if it aborts within 1 minute or within 5 minutes, 5 minutes is the time window for you. If it aborts within 5 minutes, just you will put the child in left lateral position and wait for their recovery. Telling that, and as soon as they recover, you will give them a hope that it was fine. You just had a seizure and we are here taking care of you, like this. And it is fine. Suppose if it crosses 5 minutes, then they have been taught the emergency care, like medication. It can be given and call the ambulance and take the child to the hospital.
Yeah.
This is the first aid. Maybe they can ask us.
Yes.
This we should know. Okay. But regarding the epilepsy, this most of the things we covered in our last meeting. Right, epilepsy videos, but the history will be common for all those things, as I remember. But I think
which I am thinking that history should be like onset, course, duration, about the events, pre-event, during event, post-event, and you should ask about the history of previous meal and last medication, and the previous history, past history of the similar illness, and the past history of medication, history about the any drug abuse or any toxicology history, and should we ask about the birth history, family history of similar illness. These are more than enough.
Yeah, yeah.
And others are associations which you have told, like headache, vomiting, especially early morning vomiting, any rashes on the skin of the body, and any history of loss of consciousness, all these things
Yeah,
like
yeah. So
association.
if we categorize like this, it will be easy. As you said, the event completely we will ask. But before
Yeah.
starting the event, we will ask about triggers and the aura. Triggers and
Yes.
aura is different, right? So you will ask
Yes.
about trigger and the aura. If they know that the parents will know about this, if she's known case of epilepsy, then I will ask how did it start, how did it progress, and how did it end. The entire witness should give us. Then after this, the past history of similar condition, and is she on medication for this condition. So you finished about the basic epilepsy. Then our concern is maybe tumor. So tumor related, we can ask headache, vomiting, early morning vomiting, weight loss, behavioral problems, and blurring of vision. These five
Yeah.
questions will be for the tumors. Trauma,
Yeah.
simply any head injury.
Yeah.
Infection, again fever, high grade fever, excessive sleepiness, loss of activity.
Yeah.
Right. This is for
Yes.
meningitis. Trauma infection. Then skin, deep skin pigmentation, developmental delay or regression. Then any metabolic causes. Anything
Yes.
else you want to add to this?
No, no, this
I
one.
think this will cover for all seizures. The same history will cover for all. Then
Yes.
examination is complete CNS examination. If we want just to tell them, they should know what we are looking for. So we can tell that both upper and lower limb for motor, sensory, and coordination
Yeah.
examination. And also look for the focal neurological deficit. Then cranial nerve examination. Then skin examination. You added something I did not remember. What else you said?
In the
Abdominal
examination,
also will come here.
no, that was for the tuberous sclerosis.
Yeah. But if we are suspecting tuberous sclerosis, like
Then yeah, definitely we can consider that one also.
okay, so but neurocutaneous, so mainly CNS and cutaneous examination becomes important here. And if
Yes.
the child is septic or meningitic, we can say to look for the cause of the infection as well.
Yes.
Okay. Then after examination, differential diagnosis. So for this case, how I will give status epilepticus here for differential diagnosis, I can say.
Yeah, you will say that my diagnosis is status epilepticus, and I would like to see further what is the cause behind that. Can be meningitis, encephalitis, drug intoxications, or any toxications, and any trauma, tumor, and vascular accident. What else you want to say? These are the main things.
Any metabolic causes also.
And any and metabolic causes and as well tumor also,
Yeah.
and
So the same
electrolyte
thing, what
imbalance.
we asked for the history, the same thing we have to ask. We can say status epilepticus for differential diagnosis, like maybe meningitis or encephalitis, maybe trauma, maybe tumor, or metabolic cause, and developmental delay or regression or a genetic syndrome also.
Yes.
Okay, then we will go for the investigations. As you said, I missed the septic workup here, very important.
Yeah, that is very important.
Then I think management we did. Okay, so we will go for the next one now.
Yeah.
I don't know how many left. I don't know. I think only one case is left now.
Yeah, this is only one left.
So we can finish that. I think I will give you and you will do this.
Okay, okay, no problem.
Okay. I will share the video. So this is for you, the video, watch and we will start. Okay. You want to watch again?
Yeah. No problem.
We'll start or you want to watch?
Yeah, we can start.
Okay, I will keep the time. 1 minute. Okay, you can start now.
Okay, I can
This is
see a
8-year-old
child.
child, Sattam, presented with fever with a rash 2 weeks back. Okay.
Okay. So I can see a child 8 years old with sick looking and in the hospital setting, and he's having difficulty in walking with unbalance in the walking, and some examiner is trying to hold save him from falling, and there is IV line on the left hand in situ, and placement of the cardiac leads are there.
Okay.
And in the next part one health professional is holding his hand also
Okay.
while he's working.
Mm. So, what
So
history you want to take?
yeah, so I would like to ask the history of onset, course, duration, progression, and history of associations, like in I have given fever, rash, any ear pain, and history of weight loss, and would like to ask about the headache, early morning vomiting, and any history of trauma, and his birth history and the family history as well, and history to any drug exposure.
Okay. So,
So
what
the
examination you want
examination,
to do?
yeah, examination. I would like to do the examination first of all, general physical examination as well as the complete cranial CNS examination with involving the cranial nerves examination and involving for the coordination and what else? Yeah, coordination examination as well.
Okay.
Yeah, this is and the ENT examination and the skin examination if there is any rash or anything is there or not. So I would like to do this examination.
Okay. Then, what differential diagnosis you have? A child with
So
fever
I
with
have,
rash.
yeah, I have a list of differential diagnosis like acute cerebellar ataxia, and there was a rash, so that may be due to post varicella cerebellitis, and would like to take another. This can be encephalitis or and
Meningitis,
the
encephalitis.
meningitis, and we'll think of GBS as well, but this is very less likely as the child is moving and there is movement is unbalanced, and will drug induced ataxia as well, and labyrinthitis.
Vestibulitis and labyrinthitis. Okay.
Yeah.
So, what is the investigations you want to do in this patient?
Investigation will be some acute investigation which for the acute like CBC, CRP, blood culture sensitivity, urine culture sensitivity, and complete examination, definitely BSR, serum electrolytes, and metabolic screen, and would like to do for CSF analysis and culture sensitivity to isolate the virus, and would like to do the blood for toxicology and urine for toxicology and metabolic and products, and would like to do some imaging like CT scan, MRI, and EEG as well.
Okay. So, this child has no seizure. Still, you want to consider EEG here?
uh, this will be to rule out other metabolic disease, just not for
Okay.
particular this one.
Okay. So, tell me what if this is post cerebellar ataxia? What is your management? This child is
So
presenting
my
2 weeks after infection.
okay, so my management here will be first of all, I would like to take the proper history, and as I after doing examination, will check the vitals, heart rate, respiratory rate, and blood pressure as well, and the temperature, and after that, uh, if the if this is deteriorating, then I will consider involve my multidisciplinary team, involve my consultant, neurologist, as well as occupational therapist, physiotherapist. If it is deteriorating, we'll think of IV, IG, and plasma phases, and glucocorticoid can be think of that. But usually the post-viral cerebellitis is a self-limiting condition, and usually the child's develop uh, improve, sorry, not develop, improve
So how
with
long they will observe for improvement, these children,
that
without
should be within,
IVIG?
yeah, that should be within 2 weeks at least should be improved.
Yeah,
If they are
two.
not improving, yeah, if they are not improving, then we can consider of IVIG, plasmapheresis, and glucocorticoid after involving the consultant and
And
multidisciplinary team like physiotherapist, occupational neurologist, ophthalmologist. They may have problem with the eyes, and speech and language therapist that they may have problem dysarthria or something like this.
okay. So yes, there will be 2 weeks observation for this child for the improvement. And if no improved, then the medications can be considered. So what advice you will give to the parents? Will you discharge this child?
No, I will educate the parent, reassurance, and will give the observation complete. If the child is deteriorating further, if it is start vomiting, headache,
Hmm.
or any respiratory involvement, respiratory distress, and if it's not improving within 2 weeks or deteriorating, they should come back.
Okay, so they will be the first day you will admit the child, you will evaluate the child for the cause of the this ataxia. So you will rule out by doing all the labs and also the imaging. So once your diagnosis goes with post-cerebellar ataxia, you will not give anything. It is just for observation. Then you will discharge the child, giving instructions to the parents to that their child is not able to walk steadily. So they should one parent should always be with the child, and even if they want, if they are in the job, they can take a rest and a leave can be given to them. So this is if they are not sure that they can take care of their child, they should tell us, so that we can take the support of social worker, or we can keep the child in the hospital due to social reasons. Okay, they should not be discharged. And as you said, at the home, if they see that there is new development of weakness, a weakness in any part of the body, or any vomiting, or the child is not well, excessive sleepiness or anything, they will bring back the child. Otherwise he will improve, and they just needs follow up.
Yes.
Okay, other differentials, what they can ask you for ataxia? What are the differential diagnosis for ataxia?
For ataxia, we should consider of some genetic causes like Friedreich ataxia or ataxia telangiectasia.
Tell
And
acute, intermittent, and chronic.
yeah, acute will be acute cerebellar ataxia, vestibulitis, labyrinthitis, drug-induced, or any trauma or any toxic exposure. A benign posterior vertigo, what is that called? BPV, benign vertigo, that will be acute. Intermittent, intermittent can be posterior fossa tumor or any cardiovascular accident or any stroke.
No,
Can be there.
intermittent is usually migraine and epilepsy.
Migraine and epilepsy.
Yeah, chronic is you will put all these genetic conditions like
The chronic is genetic condition, that is Friedreich ataxia
Friedreich's ataxia, ataxia telangiectasia, and also ataxic CP. You can put it easily. And also this Joubert's.
Which you told intermediate, which you told epilepsy and
migraine.
Okay.
Migraine and epilepsy, they can cause intermittent ataxia, maybe brief at the time. In and around the attacks they can have. That is why it is called intermittent. Okay. That is what it is given in mark as well. For chronic, remember always the genetic conditions and metabolic. Genetic and metabolic is chronic always. Friedreich's ataxia, ataxia telangiectasia, ataxic CP, and the Joubert syndrome. I heard once Joubert syndrome also came in the exam. And metabolic like Wilson's and vitamin E deficiency.
Yeah, vitamin E, that one I know, and Wilson I know.
And leukodystrophy as well, if you want. At least little we will remember, two examples for each, I think more than enough.
No,
Then
that is ataxia is easy.
mm,
Intermittent, I forget this one. Even I have studied before this one also, but I forget this one. I know this one. Chronic is always think of
genetic and metabolic.
Yes.
And acute, I will think of this infectious and post-infectious. Could be infectious at the moment or post-infectious. Commonest is the chicken pox. Then I will consider mycoplasma and measles. Measles is less likely because of vaccination now. Okay, because we are vaccinating for measles. Then structural lesions like this tumor is very important. Trauma, you told, and drugs, phenytoin toxicity.
Yeah, that one I told.
Yeah, bas. Okay, inshallah.
Tomorrow we will do.
Yeah, we can do. Inshallah. Tomorrow you are free.